So many of you have seen many parts of this before, if you've seen me speak. Others of you have maybe seen some parts of it on a video, which I know some families have been seeing that was distributed by the XXYY Project. Some of you might not have seen anything. And so we have a lot of different, I think, levels in this room of people who have heard me talk before. Some people have heard me talk 20 times, and some people may have never heard me speak about XXYY. We also have, I know one family who has a son with XXXY, 49XY, and I told them it was probably a good idea to come to this talk because there are more similarities in terms of medical problems and other things than there are oftentimes to just XXY, which is also covered at this conference. Is there anyone else in this room who's not either who doesn't have a child with XXYY or who has a different condition or is just here for other reasons? Just so I know. Okay. So this is the plan of what we're going to talk about. First, just a little background, how to make the diagnosis, physical and medical features, developmental and psychological features, and treatment recommendations. We also have a lot of parents of adults here, and so I've added a few things on expanding some of the things in terms of adult health that we've been seeing in some of the boys. You know, we don't have great long-term follow-up into, you know, the geriatric period, but, you know, there are some things in some of the adults that I think are important too. If you are bored because you have heard this before, then I'm not offended at all if you say, I'm going to step out for this part because you've heard it before. So, you know, this is the typical karyotype in a male, XY, typical karyotype in a female, XX, and in XXYY syndrome, we have 2 X's and 2 Y's. It occurs in about 1 in 18,000 males. 49XY is about 1 in 250,000. It's much less common. And so I'm just going to add those things in as I know them about 49XY. We know of all the X and Y chromosome aneuploidies. Aneuploidy is a genetic term that just means a difference in the number of chromosomes. So if you take all of them together, it's 1 in 400 live births. And this is a long list of all the different types of aneuploidy that can exist. And so here's 48XXY. What a lot of people will ask, you guys all know this, but if a Y chromosome is present, no matter how many X's, it's a male. You know, the Y chromosome carries the genes that codes for the development of male genitalia. And so, you know, I get a lot of questions in these conditions where there's 2 X's, whether or not, you know, oh, are they males or females? Genitalia is male. XXYY was first described in 1964, and until we started our study, there were only 100 cases that had been reported in the literature. The first paper said, oh, it's the same phenotype as XXY, it's a variant of Klinefelter syndrome, there are no differences, they should be treated the same. But then, in the last large review in 1970, they recognized that there were some additional cognitive and medical problems in XXY, compared to XXY. So, and so, you know, they actually were starting to recognize that, you know, there are differences compared to classic 47XXY. So this is where I got involved, was because the XXYY project said, you know, we really know there's a lot of differences, and we have our own organization, the XXYY Project, because XXYY is different. And so we need a doctor to document what those differences are and to tell us more about, you know, to further document the medical problems that we're seeing, because it was parents on the internet talking to each other that were talking about tremors and talking about, you know, all sorts of different problems that they were seeing in their boys that weren't being described on the XXYY website. This is the first camp we were at, and some of these kids are so big now when you look at them, and these are, you know, I mean, a lot of these guys are still here. So this is, but this was the first time that we went to camp in Woodland Park. It was 5 years ago when we actually started doing the research. And so this was me with the first group of XXYY boys. And what's happened is that we, you know, since then saw patients that were from really all around the world. We saw a big group of kids from the United States. We saw kids from Canada. I went to Europe and saw the UK group over there. We even went to Australia and saw the Australia group. But so in this paper that we published in 2008, it includes 95 patients with XXYY that were anywhere from 1 to, I think he was 60 years of age. And so that's what I'm going to tell you about is the results of this study, and add in some other things here too. So we had 95 patients. The mean age was 14. We really had a range from 1 to 55 years. And we really had, you know, a group of about a third of the patients were between age 1 and 10. Another third of the patients in adolescence, and then another kind of third of the patients after age 20. And so it actually was a pretty nice representation of different age groups. Almost all were Caucasian. We had a couple other minorities. Unfortunately, we didn't have more, which I wish we would have had. I don't think the problems are any different in minorities, but it's just nicer to see if there are differences in the different populations. So, talking about the diagnosis. Okay, so what do you get? So I added in a few quizzes in case there really are the XXYY experts in here. And so let's make a guess. What do you think the average age is when someone gets a diagnosis of XXYY? 18, 8, 15. Anyone else? Ta-da! 7.7. I have candy. Do you want a candy? So 7.7 was the average age of diagnosis. There were 2 kids who were diagnosed in the prenatal period. There were about 10% that were diagnosed less than a year of age, and that was because of heart malformations, physical, facial features, cleft palate that they did genetic testing for. The big chunk were diagnosed in this time period between 1 and 5 for developmental delays or autism spectrum disorders, so speech and language problems, motor problems. Another, quarter diagnosed between 6 and 10 because of learning disabilities and behavior problems. And then another group in here diagnosed between 11 and 19. Some of them because some of the hypogonadism or the testosterone deficiency started to show up. People noticed their testicles were smaller. Others because, it was still learning and behavior difficulties that were coming up. And then a few of them after 20 years of age. And these were usually people who went to a new doctor who said, oh, your testicles are small. Has anyone ever asked you about this? Or, oh, has anyone ever tested you because of, your learning or behavioral challenges? And then a new doctor thought to do it. So the diagnosis, you guys know, is made by a karyotype or chromosome analysis that gives you the XXYY. This is what the chromosomes first look like under the microscope. And then the cytogeneticist has to go through and match them all up and, make them into a karyotype there. They don't come nice and neatly arranged like that. That would be really handy. And so this is something where people ask me a lot, how does it happen? And we actually don't have a lot of good information. This has only been studied in exactly 6 people, where the extra X comes from. We know if there's an extra Y, then the extra Y, females don't have Ys. And so, we know the extra Y comes from dad, but we don't know exactly. So this is what normally happens to make sperm cells, right? All your eggs are X's, usually 1 X in an egg. And then to make sperm cells, first what happens is you have an XY cell that then they double, and then the X's go one way and the Y's go the other way, and then they split again. So you have, either sperm that have X's or Y's. And depending on what, if it's an XX, an X sperm and an X egg, you get XX female. If it's a Y sperm and the X egg, you get an XY male. So that's what normally happens. But, we know in XXYY, there's a couple different possibilities of how to end up with XXYY. The first one would be it happens during the formation of the sperm. And so something happens where there's a mistake where 2 of the Y, the X and 2 Ys go into one of the sperm. And so you have an XYY sperm and an extra X. In the 6 cases that have been studied, the extra X is the dad's X. And so if you have a paternal X here, then it's most likely that it came from this way, right? Because if there's no other way to get dad's X. However, there's only been 6 cases studies, and I don't believe that really represents everything. And this almost involves 2 mistakes. Like it involves a mistake and another mistake. This is the other option, is that it's postzygotic, or it happens after fertilization. So you get a normal X egg, you have a normal Y sperm, they come together and make an X and a Y. And then what would happen is these would double and are supposed to split evenly into an X and a Y and an X and a Y. But instead they go this way. And then this cell isn't going to survive because it doesn't have any sex chromosomes. And so then this population of cells divides and divides. So it's something that happens very early after fertilization. So that's our other possibility. This involves kind of one mistake. These just get stuck. So it seems more, this seems like it would be more likely to happen. If we look in XXY, it's about 50%, we think it's about 80% of the time that it's a problem with the egg or the sperm, and about 20% of the time that it's what we call post-zygotic or after fertilization. So, I mean, I think this happens sometimes. So we're studying this. And so when you guys come to Colorado and we ask you to give parents' bloods, that's part of what we're looking at. And why is it important is not just to better describe how it happens, but is there a difference between the kids who have 2 X's from mom, like these would both be maternal X's, or is there a difference if they have an X from dad? Because there's areas of the genes sometimes that are called imprinted, so they can turn off different areas of the X chromosome depending on whether it comes from mom or dad, and then it might make the condition worse in one case. So we want to understand the variability in XXYY. So this is one of the things we're studying, and I think this is also usually a question parents ask me. Okay. So then talking about physical features, I like this picture to describe the differences in physical features because it doesn't involve naked boys in black and white standing there. This is a description from a paper that is XXY Klinefelter syndrome, but it really shows the differences that can sometimes be very subtle in terms of physical changes. So when you have an extra X chromosome, you tend to be taller. We'll talk a little bit about stature, and have narrower shoulders. Gynecomastia is the male breast development. We only saw that in about 20 to 30% of our population. So it's described to everybody when they talk about Klinefelters or XXYY, but it wasn't there in everybody. The smaller testicles are there, and the fertility problems are there.
When you say the male breast development, is that full breast or just a little bit?
No, it's usually just a little bit. When we counted it, it was any type of palpable breast development. Now, you guys know normal pubertal males go through that. About 20% of males as they enter puberty have some of that also because of the hormone changes, and then it goes away. And so, in XXYY, when we count it, it means it's persistent. It's not just that, that male breast development at the beginning of puberty. But it can be very small and often, not even visible through clothing, just palpable, or it can be more significant. It's usually not, and things that can increase it are increased body fat, because increased fat grows in there too, just as women gain weight and their breasts get bigger. So it can be more apparent as well.
So with the XXYY group, is it like with the 20% they get it compared to XY? Theirs comes and goes and comes and goes, but with the XXYY it comes, but then it doesn't quite go.
But then it doesn't go, yeah.
So it comes and goes, and then all of a sudden doesn't go, or?
Well, usually in typical XY male puberty, if it's present, it doesn't happen in everyone, but if it occurs, it comes and then it goes. It doesn't go up and down. It's just, 12, 13, 14, and then it should be gone. Mm-hmm. In XXYY, if it stays, it's present. And then it reaches a certain level, but if you gain weight, it can be more apparent.
And have they found anything?
We don't know how to, the treatments for it, there are 2 treatments. The first one is making sure they're on testosterone appropriately, because when we see gynecomastia, we think that there's an imbalance in terms of increased estrogen, and we want to make sure that they have the testosterone. If it's really a concern for the families, or more for the guys themselves, there have been males who've had surgery to remove it. And so, and I don't think there's anything wrong with that if the guys are really self-conscious about it. Then, it's a fairly simple surgery, and it definitely, a lot of guys, and I haven't had guys with XX, well, there's actually one guy with XXYY in Europe, I think, who had the surgery. But there's a couple guys with XXY who have had it. And then, even as, in their mid to late teens, you want to make sure you're not doing the surgery before it's going to go away or before the testosterone can treat it. But if they're, 17, 18, 19, it's probably not going to change. Okay, so the average adult height in XXYY. You guys may have learned this already, because wasn't there another one on growth? 6 feet, 3.7 inches, which is great. And so the height in XXX, so the height in 49XY oftentimes is shorter stature. So something happens where the X and the, with 4 chromosomes, they get taller, and then with 5, they're shorter. It's the same thing in the girls. Tetrasomy X, they get taller, and then pentasomy X, 5Xs, they're shorter again. Well, sometimes it's short stature. Other times it's typical stature. But it's not usually tall stature. in XXYY, we don't see it necessarily before they're 10. Some of the guys are really tall before they're 10, but the average height was right at the 55th percentile in the group that was less than 10. Then when we went to the teenagers, the average height was in the 70th percentile. Then when we went to the adults, the average height was in the 97th percentile. So they grow more through adolescence, and they get increasingly taller.
Have you done any comparisons to like the family?
Yeah, even in comparison to the family. So the height in XXYY is not just related to XXYY, it's also related to the family history. So some of the, obviously, some of the kids may not be tall for, they might not be 6'4", they might be 5'10", but for their family, that's very tall. So this is usually stature out of proportion to what you would expect for family history. And we've seen a couple kids who are really short and have short stature too. So, we have a big variation in stature, but on average, the average height is taller. These are some, you can see here, this is a lot of guys, I think at the first conference, which I wasn't at, but I like this picture. This guy's blocked out because it was really a dad, and so, who had a bigger belly than any of the kids. But I like this picture because you can see, when a lot of these guys are clothed, you can't really tell the difference in the body habitus. But you can see all their little bellies even there. And at this conference, you can see some of them have bigger bellies than they used to. And they're growing a lot around in the belly area, which is what I'm noticing each year, kind of. And so I'm really concerned about that for the adults, because that is big risk factor for diabetes and heart disease and all sorts of things with that distribution of fat around the waist. Yeah?
And philosophy, really like to be related to medications that are taking, like Risperdal or something like that.
Some of them, yeah.
Because that makes a huge, I know Robert gained 40 pounds on Risperdal, and we took him off, and he lost 50.
Yeah. Yeah, weight gain can definitely be related to medications. There's a lot of the medications that we use for behavioral control that can be related to the weight gain. The sugar cravings play a big role in some of the weight gains, even in the guys who aren't on medication.
So they do have the pot bellies like that. Does exercise help that?
It can help it, but I think, even in the thin guys, you can kind of see it, right? So, some of it is the fat distribution that is probably genetically determined. You can also see kind of the thin calves with the, they don't have a lot of definition in their muscle bulk. None of them have all this hair growing off their chest, so, they don't tend to have that really, hairy piece that comes along with the testosterone. So these are some of the other physical features that a lot of you, most of these, some of them you do things about and some of them you don't. The curved pinky fingers, you got, a lot of the kids. This is also the nail biting sign where they all bite their nails a lot. You don't do any, this doesn't hurt them. It doesn't, if they have more curve of a pinky, it doesn't mean they have more problems, but it's just one of the features that we can see sometimes. The genuvalgum is knock knees or flat feet. It's because of the low muscle tone and the joint laxity, and you can see them have problems there. This little guy did have XXYY. Some of them needed braces in their feet. Some of them do better with inserts in their shoes. Others, won't wear them, or it doesn't really help them much anyway. The elbow abnormalities, this is one of our XXYY rodeo stars in Oklahoma, so he had his big rodeo belt. There's a funny story with him. You guys, some of you guys have heard this before, but others of you haven't, so I'm going to tell it. Is that he was sitting on the table. He's this kind of big guy, so even when he was sitting on the table, his hands were like right here when I was looking at his hands, and he said, and he wasn't biting his nails, and I had never really seen anyone who hadn't bitten their nails before, and so I said, oh my gosh, you don't bite your nails. No, doc, I used to, and I was still looking down at him. And I said, well, how did you stop? Thinking I was going to find the cure to tell everyone else. And he smiled at me and he's like, well, I don't have my teeth anymore. And with all his dental problems that he had, which you guys all struggle with often, he didn't have his teeth anymore. And so he couldn't bite his nails. So I found the solution. No teeth. It was really funny. I was like, I can tell that only to one group of people who will laugh at it, and the other, no one else is going to think that's very funny. And so the other problem, so you can see what we call cubitus varus, or kind of this what we call a narrowed carrying angle of their arms, and the funny elbows, and a lot of the guys will compare them. Sometimes it's due to radial ulnar synostosis, which is a fusion in the bones of the elbow, or of the forearm. So this is a normal elbow. And you can see 2 separate bones. And then here is a fused radius and ulna. So what it does is it limits this movement here. They can't do that. So they end up stuck or very limited in what's called their supination and their pronation. It's important for OTs, PTs, parents to recognize, because sometimes some of their movements are different. You know, one guy couldn't carry his books and he needed an accommodation to have a special book bag at school. Other times the OT was trying to get him to do it. You know, other times they have to sit funny to be able to write appropriately. So, you know, it can cause some limitations. There's usually nothing you do about it except recognizing it and then recognizing that maybe there are some accommodations like that that they might need. Surgery, we had one guy with, I think it was XXY, who had surgery because he was involved in sports. And after the surgery, to fix it, it was actually worse and painful. Most of the guys, it doesn't hurt them. They just have that limited range of motion. And then flat feet over there again. The other things on the physical exam that we saw were things like epicanthal folds, which is this little inner fold on the inside of the eye. Hypertelorism, or wide-set eyes that you can see in some of the patients. Full lips. And then bitemporal narrowing, which is the narrowing at the temples in the older kids. And you can see that in some of these guys as they're walking around, that they have kind of this narrowing in here and kind of then the more prominent cheeks and that part. Yes?
Have you only seen that in XXYY?
Mm-hmm. Well, you know, that's not true. I think there's a more subtle head shape of that same difference in XXY. And I notice it more in the XXY babies, that you can see it a little bit. And then, I don't know, but not to the same degree in other conditions.
I noticed that Kyle is getting more. I mean,
it's becoming more as they get older. You know, this is kind of the progression of different features, and I think it's important. Some of the guys have more significant facial features that look atypical compared to others. You know, there's some kids who, you know, we don't, you know, they're all great, handsome kids, but as doctors, you sometimes would say they're more dysmorphic, or they have more signs or symptoms of what you would see as a genetic disorder that don't necessarily stand out to the general population, but we notice these little details of things. And so some of the kids, you know, you do notice things that look a little bit more atypical. You know, Aiden here, you probably would never suspect that there's a genetic disorder. This guy over here, but other ones you see some different features, and you can see a lot of, if you look at this guy, and then Zach, and then, you know, they almost look like they're the same kid getting older and older and older. So there's definitely the physical characteristics that you see that can be very similar. And then you can see also as they get older, their faces are getting longer. You're seeing more of this bitemporal narrowing in a lot of the guys. And so you're seeing their features coarsen. You know, the full lips you're seeing come out a little bit more that you don't see quite as much when they're younger. So I don't know what's happening there. I'm working with our endocrinologist who, there are some hormonal changes that can do that as well. Males tend to coarsen as they get older anyway, but it seems to be more in this group. So then these are the comparisons. You know, some of the things we saw more commonly in the prepubertal group, and some we saw more commonly in the postpubertal and adult group. And some of the things, you know, the important thing here, all of them had small testicles after puberty and in adulthood. This is important because, you know, I think testosterone treatment is likely very important in almost everyone with XXYY. I haven't met anyone yet who really sustains their normal testosterone levels and don't need replacement. Sometimes they can keep it up at the beginning of puberty, but then they tend to go back down. And then, you know, dental problems in almost all the adults, the curved pinkies, the flat feet, elbow abnormalities where they had some restricted range of motion, tremor coming up along in adults. Gynecomastia was only 33%.
You know what I've noticed when I've been talking with a lot of the people who have older boys,
What?
and especially in Dale, not only does he have a hand tremor, he's getting leg tremors too.
Really?
And on the same side of his body.
When do you see it?
When he's standing. And actually, when I went by that student lounge, there were 2 XXYY boys at the computer, and their legs
You can see their
were
legs.
going.
Wow. Yeah, I'm worried about
But
that.
he's worried, it's when he's standing, just
Huh.
standing. I thought maybe it's like when you put your foot down and it
Yeah.
does that, but it's not. It's when he's standing.
What is that, hypertelorism?
Hypertelorism is wide-set eyes, so how we were showing in some of the other ones. So, and the folds are the folds in the eyes. Yeah, so, and you guys will, I mean, Jason showed me his, in that he's like, well, when I'm just sitting there, it doesn't shake. But when I put my sandwich in this hand, it shakes. But then when I take it out, it doesn't shake. So intention tremor is when you're intending to do something, it shakes, compared to a resting tremor. And a resting tremor is more like Parkinson's, where you'll see them tremoring at rest. And that's not what we typically see in XXYY. We see that they shake when they're intending to do something. So, smaller fine motor tasks get more difficult. This is a picture of, basically you guys have probably heard a lot about testosterone while you've been here, so I'm not going to spend a ton of time talking about testosterone because it's not my main field, but it's very interesting to me. So this is testosterone levels in the typical population is this gray solid one. So, they're pretty low until 12. They go up at puberty, and then there's a big range of normal. If you test kids with XXYY, they're here before puberty. They go up, and then they either kind of plateau or they fall off. There is no answer. All these question marks are, when do you start testosterone treatment? Do you start it here at the beginning of puberty? Do you start it here when you wait to see that they're low? Do you start it here when they start to fall off? Or do you start it when they have symptoms, gynecomastia, no more pubertal development, poor endurance and fatigue or weakness? And no one studied this at all. So this graph is actually from a grant that we submitted to see, to say, we really think we want to see what happens when you start it here. And do a nice controlled trial in XXY and XXYY to see the differences in the kids where you start it here and the kids where you don't. So, because it really seems that once they start on it, as long as you do appropriate dosing and monitoring, that a lot of them have some positive changes in terms of both physical development and motor skills, but also cognitive and behavioral problems or behavioral development. If it's, or at least we need to study it to know, because no one knows these answers yet. So,
we were concerned about height.
yeah.
And when Jesse was first diagnosed at between 11 and 12, he looked at his hand, and the doctor said he could predict his height from his hand, and said he'd be 6'4". But then we started the treatment pretty early at 14, and he's only 5'11".
So that probably makes sense. So bone age can tell you kind of where you are in terms of your overall. So when you look at your bone age, and then we compare it to your actual chronological age. Sometimes bone age is delayed. So it'll tell you you're going to grow for longer. And if you're following a certain growth curve, you're going to keep following that curve for a couple years longer if you're delayed. The starting testosterone treatment helps fuse the growth plates. And so it will stop growth. And if you start too much testosterone treatment too early, or kids who have early puberty and extra testosterone treatment, they'll grow and then they'll stop because their growth plates will fuse. And so, we have that's not the only reason why guys with XXYY grow taller, but it definitely, some guys who are growing, and their testosterone is kind of coming down, we think, it's important to start testosterone in them so they don't reach these extreme heights. Height is a wonderful thing in our society, but it can be a disability at certain levels where there's a lot of accommodations, and even in our guys especially, there's these big giants who sometimes have behavioral regulation difficulties, and I'm not scared of them, but I can see why if they're getting frustrated, others would be scared and intimidated.
So would you recommend that for people with younger children to bone age?
Yeah, it's usually part of the evaluation of when to start it, is doing a bone age, doing a testosterone level and an LH, and then figuring out, where they are. You don't want to start it, if their bone age is way down here, like let's say their bone age is 10, you don't necessarily start testosterone right at that time. You want to wait a little bit and let them progress.
So do you wait till they're like 12 to first go in?
You'd ask 100 people. Oh, no, well, yeah, you want to wait until they're about 12 or 13. Yeah. This is, so this is what we see at puberty, delayed puberty or incomplete puberty. They start and then they either fade off, like I said, or they really don't start that much at all. And that's related to testosterone deficiency. They have low body hair, little or no acne, little or no testicular enlargement, persistent gynecomastia, which again we see in 25 to 40%, and then the fertility differences. So the point of the treatment is you go to endocrinology starting at 10 to 12 years of age just to meet them and start getting all these things with the blood monitoring of their hormone levels and the bone age x-ray. And then you do testosterone therapy, somewhere in here, but definitely when you start to see the testosterone start to go down. And your goal is not to, make them have testosterone up here. You're replacing it. And so it's not, some people, it's really scary to some people, but it's really replacing something that their body needs and isn't making. There's a lot of different formulations. You can do the injections that occur every 2 to 4 weeks. You can do the gel that's daily. There's a lot of new formulations in research where you can give an injection that stays at a pretty steady blood level for 3 months. There's pros and cons of each. The injections, you give it right now, the ones they use, you give an injection and then it comes back down. You give an injection, it comes back down. The gels are pretty much every day you put it on. However, some of the guys with XXYY, even though they might not like shots, are certainly not going to do well. They don't put their gel on. They're not remembering. And so, or they just don't do it because they're not taking a shower because they're not doing anything. And so, so you really want to, make sure even though there's benefits to each one, that, each kid is really different. And you have to make sure you're doing what's right for the child or the adult. How many people here have kids or young adults on injections? Yeah, and how many are on gel?
How many started on gel?
Yeah.
Started on gel too.
Yeah. A lot of people think it sounds better, and then they don't do it. So, did you see more mood swings after going to the shots or not?
No.
How often do they get them?
Every 2 weeks.
Yeah. So the 2 weeks is a little better. Yeah?
There's I just found out from our endo in Colorado that the implants are available now in Colorado. There's not that many doctors doing it.
Right.
So, but we found one.
Good.
Kyle's all up for that.
Oh, he is.
He said that it would last, they're supposed to last up to 6 months,
Yeah.
but it looks like they only last about 3.
Yeah.
Does that make sense?
Yeah. So there's new little pellets, and it's actually a little bit more of a procedure than it sounds like. It's not just a shot, but they're little implants of testosterone pellets. And they do a procedure where first they numb the skin, and then they kind of bore a hole. It's not a huge hole, but a hole into the skin, and then they implant these pellets in there. And then it delivers a steady blood level for 3 to 6 months. And it really depends. After the first time, you can't just be starting on testosterone to do it, because we don't know how much you need. But once you're on a pretty stable dose, in your late adolescence or your 20s, then you can get the pellets, and then you just have to do it, at that frequency. It keeps your blood level the same. I think in the future, those are probably going to be replaced pretty quickly by another medication that's called Nebido. I don't know if any of you guys have heard about this. Nebido is an injection that then stays there for 3 months. And so it's 4 shots a year instead of this whole procedure where you have to numb it and implant them and stuff. But I mean, in the meantime, I saw when I was in Australia, I went and observed the implants be injected in one of the patients, and he's really liked them. So, I think it's good. I think it would be. I mean, it'd just be more convenient as well. One procedure, and then you don't have to think about it for at least 3 months.
Once you get your testosterone level right, when you're like say 20, 23 years old or whatever, do you pretty much stay at that level, at that dose, like all your life, or would something?
Sometimes and not. There are some, like even when you're getting testosterone replacement, some people are still making a little bit on their own. So what you don't want, but that can change or go down. And so, I think once you're on a level that feels right to the guys, and you don't have to check it every 6 months, but every couple years, you really want to make sure that they're still staying on track. You should be seeing the endocrinologist still every year at least. And so, I don't think it's bad to do levels. I have a feeling as they get older, they're going to need more. I don't know for sure, but that's what we tend to see in XXY sometimes. So what does it help? It definitely helps with pubertal development. It definitely helps with muscle strength, bulk, and endurance. It helps with prevention of osteoporosis, which is very important. And we don't know that it helps with moods and behaviors. I've gotten a lot of parents who have said it certainly doesn't hurt in that area. And I don't know, I love to do this survey in the room. Has anyone seen worsening of behavior on testosterone? At the beginning?
I see worsening when he's due for a shot.
You see worsening when he's due for the shot?
It's almost like he's having PMS.
Yeah, yeah. I've heard of worsening of behavior in 2 kids. One was when they tested it afterwards, it was way too high. And then the other one, I think were starting too early, and he was starting to have worsening of behavior anyway. And then they thought, oh, testosterone might fix it, and it didn't fix it. And so it was something else that was actually going on at the beginning of puberty. But we're studying this right now. So if anyone is having their kids starting on testosterone, we want to study what the cognitive changes are, the behavioral changes are, the motor changes are. And so in Colorado, we will have you come and do, a pretty big battery of testing for 2 or 3 days before, and then you can start on your therapy. You can get treated wherever you are. And so, you don't have to come back every week or however often for the therapy. Your endocrinologist can do the therapy how they prefer. We just want to follow it and follow how they do. At 6 months, we'll send you some questionnaires, and then we'll see them again at a year. If you can't come to Colorado, absolutely no way. We do have some funding to help, and we want the XXYY kids coming. And then if you can't come at all, then we definitely can send you questionnaires at least to do in the mail. And so we won't be able to do all the assessments, but we can do the questionnaires. So what testosterone doesn't treat is the fertility difficulties. So that, the reason there's testosterone deficiency is because the testicles have atrophied and don't make testosterone and don't make the sperm. And so replacing the testosterone helps with that one problem from the testicular atrophy, but it doesn't help with the fertility problem. Yes?
The mood behavior thing that you were talking about, on the one child who had levels too high, which levels are you talking about?
Total testosterone level. Yeah. Here's some other significant medical problems that we see: dental problems, asthma, hand tremors. This is in the whole group, 60%, so that includes some of the younger kids. So as they get older, it becomes more prevalent. Heart malformations in 20%. This is important because this is different than XXY. And so, we really usually recommend that newly diagnosed patients have an echocardiogram. If your child is 20 and has never had an echocardiogram, don't worry about it. You would hear murmurs at some point or see problems related to it. But if they do have one, it's nice to catch it early and know what's going on. Seizures in 15%. Again, this doesn't usually develop in adulthood, but it would develop, usually is in childhood. And then we've had many kids who have had seizures in childhood that have then improved and gone away. Really?
He had Ben Long.
Yeah.
Now he doesn't have any seizures at all. It's not on any.
And is not on any
Of course,
medication.
he has the top 6. Except he has diarrhea and severe constipation.
Really?
But he does have bowel symptoms.
Yeah. In 49XY, the dental problems all of these are also more prevalent. I don't know in these exact percentages, but they can all definitely be related to 49XY as well. Yes?
If they've had seizures as children, have you seen any, and they stop, have you seen anybody start up again? Our child stopped, and we're just assuming that's over with.
It probably is over with. Now, if you've had seizures once in your lifetime, you're at a higher risk always, and this is just in seizure, not even in XXYY, of having seizures return if there's big electrolyte imbalances, sometimes with dehydration or calcium imbalances or other things. If you have an infection, there's some inflammation in the brain related to meningitis or encephalitis, you're more likely to have seizures again. So, your seizure threshold is usually lower if you have a history of seizures. Drugs that can induce seizures, so. These are the MRI findings in XXYY, and you can't see it really well because that light is shining so bright in my face. But you can see here these white spots that enhance or that are brighter. And this is something we just saw. We got all these MRIs from everyone who'd been, seeing different doctors and getting MRIs around the country, and it was all described by different radiologists in different ways that was saying, enhancing white matter lesions, areas of white matter gliosis, areas of white matter changes. And so we actually collected all of those and had our neuroradiologist look at them. And she saw these abnormalities in 50%. And so white matter is the myelin, or the connection tracks between the brain. And some of this was, it's very interesting. It was kind of funny because I can't tell you before this how many parents said, it just seems like the areas of his brain aren't connecting. you know. And then this was kind of like, oh, well, there are actually, you know, maybe some differences there in that myelin and in those connections. And so when we looked at these, though, the important thing is that we saw them in kids that were young and in adults. So it wasn't something, you know, we saw them in some kids who were as young as 2 and 3. So we think it's something that was there probably developmentally. It's not something that they've acquired over time. And it also didn't seem to make a difference. So when we looked at the kids who did have the white matter abnormalities and the kids who didn't, there weren't any differences in cognitive scores, like IQ scores. There weren't any differences in, you know, in seizures, in tremors. So we couldn't associate finding those white matter changes with anything else. So I have a feeling this is just really that. The areas of the brain, you know, all those axon tracks, which are going back and forth between all the different areas of the brain, there's something that's stopping that connectivity in certain ways. It's not stopping it altogether, but, you know, and most of them are really around the frontal lobe that we see. We see them usually up here, and that frontal lobe is in charge of, you know, what we call executive functions, planning, inhibition, attention span, all that stuff. What? Impulsivity. And so, you know, I think it's an interesting finding. It didn't correlate with ADHD. So, you know, I think it's probably there to some degree in everybody, but we can see it in some of the boys more than we can see it in others on the actual MRI scan.
His doctor attributed it. He said it's probably because of his ADHD.
That's probably why he has ADHD. So, you know, there's nothing you do about them. You don't cut them out or change them or anything. But I think it's an interesting finding, and it's going to be a clue. You know, we're actually going to start at the Mind Institute. So one of the psychologists there is going to do some imaging studies, starting in girls with XXX, to look at some of these white matter changes in connectivity. And then hopefully we're expanding that to XXY and then XXYY also.
Weren't they also, I don't know if the funding got discontinued, but they were doing something for ADHD too, right, with the MRIs?
The Mind Institute is doing a gazillion things. So I don't know their ADHD studies. They have an ADHD study there. Yeah. ADHD clinic. Dan is from the Mind. He's our videographer. Okay, so then these are some of the other medical problems that we see show up kind of in adolescence and adulthood. So scoliosis is one that shows up. It doesn't usually show up in young kids, but it can show up in adolescents as they're growing through that growth spurt. Most of the time they haven't needed any interventions. Some of the kids have needed surgery or braces, you know. So most of the time it's just mild scoliosis, but it's important to screen for and watch for. Once they hit adulthood in their final adult height, they're not going to develop it. So it's that time during adolescence that they do. Hypogonadism in the adults, all of them had it. So, you know, we've talked about testosterone treatment. Hypothyroidism in 10.5%. So this is something that, you know, that's not that high of a percentage, but it's important to keep your eyes out for. If you're seeing them be all of a sudden more tired, all of a sudden gain more weight, all of a sudden, you know, have, you know, dry skin or dry hair, then those are some of the signs of hypothyroidism. It's an easy test to do. So if they're testing testosterone, then, you know, they should test thyroid as well. And I think this should be done really every year. Obesity was anywhere from 10 to 32%, depending on the age. And this I'm concerned about because of the increased risk it then leads to for diabetes and heart disease and high cholesterol and all those types of problems. Deep vein thrombosis or blood clots in the legs. 18% had them by the time they were adults. So this is important, and I'm going to spend the next slide talking about it. And then the other thing that I thought was really striking was that in individuals who were over age 20, 36% of them had been hospitalized at some point for psychiatric reasons. And so this is a big percentage, and I think really points out the degree of emotional and behavioral difficulties that some of these kids can have. And, you know, I think this is a really important area to focus on, and we've been focusing on this a lot. Mm-hmm.
Is that related to the testosterone treatment? Because the guy in the previous seminar said he was suicidal when he was not on testosterone.
Yeah.
Well, yeah, but probably not, because a lot of these occurred. I don't think it's all related to low testosterone levels. A lot of these occur even with adequate and good testosterone treatment, and a lot of these occur even in childhood, you know, before testosterone kind of comes into the picture. So while there definitely may be some of the kids and young adults who have been hospitalized related to, their depression or other problems have been related to testosterone differences, I would say the majority of these are not related to testosterone, and they are more related to inherent mental health types of problems. Okay, so blood clots are usually rare in adolescents and young adults, and I was very struck by how frequently these guys had blood clots, and usually in their teens and young 20s. So those people guys don't get blood clots, first of all, and usually if they do get them, they're older. And so I think it's important for you guys to be aware of the symptoms, because blood clots can be very dangerous in terms of having part of the clot go up into the lungs, and that can lead to respiratory problems and oxygenation problems, and you can actually die from having blood clots. Most of the time they aren't deadly, but it's something that there's enough risk factors and other things that are important for you guys to know about. So the symptoms are usually swelling in one leg a little bit bigger than the other, pain in one leg more than the other. Sometimes it can radiate, so it's not necessarily pain in the leg that has the clot, but it's more up in the groin area. So these are things just to kind of pay attention to. If there's a pulmonary embolus or that blood clot in the lungs, you can see shortness of breath with exertion. If it's a really big one, you just see a lot of shortness of breath. But other ones, gosh, I can't walk as far as I was before. Those types of things can be related to, and then getting out of breath really quickly when they climb the stairs or something else can be related to having little clots at different parts in the lung. The risk factors, and these are important, one of them is immobility. So if they have an injury where they have to be up in a cast or have a broken leg or a surgery, it's important that you guys talk to the doctors about, he's at risk for clots because of his XXYY. So is there anything we can do to monitor, to check, to make sure they're getting them up and out of bed, or what? Usually it's just exercise and physical therapy helping them move that helps them. Smoking is a risk factor, so this is something that's really important to try and obviously keep the kids away from for other reasons, but when you put it together. Hormonal imbalance, so, we don't know why guys with XXYY get clots more often, but some of it may be related to, sometimes treatment with testosterone also leads to some elevations in their estrogen, or they have higher estrogen levels a little bit. And so any kind of hormonal imbalance, that's why women are more likely to get blood clots, especially around pregnancy and things, is because of estrogen effects. And then there's other genetic factors. There's some gene mutations that lead to increased risk for blood clots if there's a family history of blood clots. And what I think is happening in XXYY is there's maybe 2 or 3 of those that are all contributing. And so you have a combination of one risk factor from this, and then another risk factor from a genetic and family history, and together that makes them be more likely to have clots. And you're not seeing it in other people in the family as much because you don't have that. But so this is important. So we want you to tell your doctor about this risk, especially if you see any of these symptoms. And if you see these symptoms, don't just attribute it to, oh, it must be a bug bite, but we don't know where he would have gotten a bug bite to make his leg swollen. You want to be aware that this is a risk that can happen. I don't know about blood clots in 49XY. I haven't seen that many adults, and this is usually young adults. The other thing that has come out in one of the other papers is an increased risk for non-Hodgkin's lymphoma in adults that have led to increased actual mortality in XXYY in a big study that they did in Europe where they followed tons of people. And so this is rare. I haven't seen it in anyone myself, but I think it's important because it was reported in the literature. And so symptoms of non-Hodgkin's lymphoma are flu-like symptoms, fever, malaise, fatigue. This isn't, if they have these things, they most likely have the flu. If they have these things for 3 weeks, 4 weeks, then, it's something to just say, why is he still having fevers? This isn't a typical course of the flu. Night sweats, weight loss, pale skin, lymph node enlargement, shortness of breath. So these are things just to be aware of. Yeah.
Do you know, the age that seems to happen? Is it when they're a little bit older?
It's in adulthood. So, it's more 20s, 30s, 40s. None of the reports were in kids. So, but, even in their 20s, if you see it, this can definitely show up at that time. Okay, so now we're going to talk about developmental and psychological features. Almost everyone in the study had either speech or motor delays, but not everybody. So, 91% with speech delays, 74% with motor delays. The average age of walking was 18 months. The average age of first words was almost 2 years. And so, the range was anywhere from 12 months, totally normal, to 33 months, which is very late. The range was anywhere from 10 months, which is, early or normal, to 64 months, which is late. So there was a really big range of the developmental differences. I like to show this normal curve because this is what we can use to describe anything in the population. We have height, for example, follows a normal distribution. You are at the 50th percentile. Most people cluster around that 50th percentile. Then there's 2 standard deviations, the 97th percentile. You get less people up here at these extremes of percentile. These are the standard scores that we use to describe things like IQ. And so the 50th percentile is 100. And so, this is what the normal curve would look like in the general population for IQ scores, for example. Less than 70, anything between 70 and 130 is considered the normal range, the average range, because there's normal variation. Things outside of those are considered in, the extraordinary ranges. And so lower than 70 or above 130. And so what we see when we look at XXYY syndrome is that they also have a very broad distribution and follow a normal curve. However, their curve is shifted down. And so there's a lot of overlap in many areas between what we see in XXYY and what we see in typical XY males. However, there is also some differences. So our average IQ that we saw in our population was in, I think it was 82. It was in the 80s. So you can see that there are many kids who are in these normal ranges up here, but there's a higher percentage of kids who would fall below 70 and be in what we call the mental retardation range, or now what we call the intellectual disability range. And I think, it's important that we see the kind of this range, not just in IQ, but we also see it in, all the different other things we see associated with XXYY. Some of the kids have more anxiety than others. Some of them are having, anxiety that's more significant and really a disability. Others don't really seem to have much anxiety. Some kids have more ADHD symptoms than others. And so, all of it is still a spectrum. But this is, the spectrum in XXYY is shifted. So these were our mean IQ scores from the patients in the studies. The mean verbal IQ was 74. The range was anywhere from 55 to 100. The mean performance IQ score was 87. That ranged from 62 to 108. And then the mean full-scale score was 77.8, with the range all the way from 54 to 102. So they're really big ranges. And then these are the averages. So adaptive skills refers to life skills, kind of how you apply the knowledge that you have into day-to-day life. Do you, cook for yourself, take care of things for yourself? Are you able to get dressed and take a shower without needing to be reminded and brush your teeth and all those things? And we expect adaptive skills to, no 12-year-old can do all those things. But some 20-year-olds can do all those things. And so there's a normal range of how we measure, adaptive skills compared to normal kids also. So one of the striking things that we saw, and I think parents describe this often to me, is that, his IQ score is really good. Like some of these guys have very normal, good scores when you do the testing. But wow, how come he still can't figure out how to take a shower when he can take apart this whole thing and do all these really cool construction things and, And so what we saw was that there's a significant discrepancy between what their adaptive functioning is often and what their IQ scores are. In a couple kids, it's actually the opposite. They're doing better adaptively than we would expect for their IQ. And that's a really nice thing to see. But the trend of what we saw in the XXYY group was that their adaptive scores were lower than we would expect for their cognitive abilities. I would say a lot of adults describe that to me, too. I mean, a lot of parents of adults describe that to me as well. You guys have questions about that? Yeah.
I know that when Dale wanted to apply, we wanted to get him in for benefits and things like that too. They recommended that we do an adaptive IQ test.
Thank you.
The Vinland one,
Yeah.
because it was it reflected more of his capability of functioning in society, which is how they based whether he gets better.
Thank you, because that's actually why we also put this into the paper, is because for disability services in the United States, they often focus on your IQ scores and then your adaptive scores. And in a lot of our XXYY guys, their IQ scores may be low, but they're not in the intellectual disability range. However, parents need supports and services and job coaching and different options for different services. And so adaptive skills, low adaptive skills, also are another way that you can qualify. And so what we tend to do, and this I was actually happy to see was less than 70 on the average, and that's why we put it in the paper. So parents had a piece of paper that said, these adaptive scores are lower in the big group also, So adaptive skills can definitely be helpful in helping you qualify for other services. The test you do, the most common one is called the Vineland. And it's an interview in all these different areas of motor skills and socialization and home skills and self-care skills. But there's some other ones as well that are different. There's one called the CIBR. There's one called the ABAS. And so there's a lot of different adaptive measures that people give.
So this explains why Jesse is so good with the computer, but his room looks like just a nightmare.
Because he has maybe some strengths and some skills and weaknesses in other. I think that these adaptive skills are impacted because their IQ scores do not reflect executive function and that frontal lobe function. And frontal lobe function is what you need to apply your intelligence. You need to be able to inhibit impulses, and you need to be able to organize and concentrate and figure out a plan of how you're going to, execute something. And so while they may be able to do it on the IQ test, actually applying it in real life takes a lot of other abilities. And that's what they seem to be lacking very significantly in XXYY. And so that's why I think these scores come to be much lower. This is real life. And so we can do all these fancy schmancy tests of IQ and everything else, but what really you guys care about and anyone cares about is how they're actually functioning in society. And so this score is actually a lot more, to all of us, more important.
Can an IQ test change from a 70-something one year to a 50-something next year?
Yeah, sometimes. It depends on a lot of things. Rebecca might be able to speak to this a little more. It depends on the test. It depends on if there's something else going on with the kid that's leading to, more problems. It depends on tons of different factors.
Medication. It depends on if you're changing between the tests we give to younger kids and the tests we give to older kids. Yeah, we do see them change.
In our study, what we saw.
That significant of a change, I would certainly want to.
Well, I'm in school bad and they did an IQ test and came back with a 50-something and wanted to put them in a different class.
Yeah.
I don't know.
So you just want to make, I guess.
Yeah, that's significant of a change is, you kind of say, well, it's, in general, between IQ tests, they should be fairly similar. However, what we have seen, and what's important to know, is that what you test in a 2, 3, 4, 5-year-old on an IQ is, pretty simple basic stuff, and a lot of it is stuff that maybe they've seen before in different ways. As you get older and older, those scores are being compared to their peers. So if they're not keeping up with what their peers are doing, the IQ tests get much more complex, much more abstract. They've got to problem solve. And so if they're not keeping up with that complexity, especially with the higher level stuff, then their IQ scores can drop because it's compared to their peers, compared to what, 10,000 typical 13-year-olds would be doing at that age. So sometimes those scores can drop if they really don't seem to be making the normal cognitive progress. When we looked, so this was the change with age. And so what we saw was that, now you have to know that this wasn't change with age in individuals. We haven't followed kids over time and said, this is what happens to their IQs over time. Because remember, it's only been 5 years since we even started. But this was when we took a group of, younger kids. Then we took a group of, kids, later on in childhood. Then we took a kids of young adults. Then we took, older adults. What we found was that the verbal IQ scores in those groups went down significantly. The performance IQ score, which is visual spatial skills, didn't change, and full skill IQ didn't change. So their language skills seem to get worse with age, and I think that may be because the language becomes more complex. The other thing was that, the oldest group were a group that were probably more impaired in terms of functioning. So maybe it's just that group had a lower verbal IQ. So we still need to follow longitudinally to see what happens with time, to be able to help families with that.
Can't you get them through your school records? I know Jesse started school at 18 months. He has.
Yeah. We can look. We have a lot of IEPs and a lot of stuff where we can see. The problems with some of that is that then you don't know who's testing. Like, it's not us testing them each time. And so, you know, all of those variables, you know, we don't know whether to trust them. It's standardized because it should be standardized, but it's not really rigorous research standardized. You know what I mean? Like, all of those tests should be administered by professionals who are, you know, trained on how to give them in the standardized way. But it's not like a research standardized. You know, I don't trust necessarily that. I trust when Rebecca gives a test.
Jesse's has been very consistent.
Has it?
All his life.
Yeah.
About 5 points lower than your scores.
Yeah.
Except the adaptive. I don't know if he's ever had an adaptive
Yeah.
test.
If there, I mean, if anyone doesn't live in Denver and just wants to know, there's some we can just mail you, and we're happy to score them if you guys need it for something.
In school, sometimes they take kids out of class to test them. They're done, and it's a school setting rather than,
Yeah.
you know, it can be different.
Yeah, he's had him under research testing and Department of Education school
And
testing.
that would be a good study.
And it's always private that I paid for, and it's always been
The same.
within a couple of points. So, yeah.
That's good. That's easier to, then you know it's right.
Yeah.
So this is getting quite depressing.
Yeah.
So, I mean, is there a chance for any of our boys with XXYY to like lead a normal life? Are they gonna all just like?
Well, there's at the end, these are what we know about the adults, okay? So I do think there are chances for them to lead a normal life. I have not met any adults who haven't needed some sort of supports, okay? So there's a big range of support. So this is what I want to talk about here. Now, there are some children with XXYY that I'm following now who I feel are doing better than what our research is finding, because the older adults that we have were likely diagnosed. If you think about genetic testing, now we test everyone. If they have a little speech delay, we're more likely to test them and find them and do all these interventions and treat them. So I think those kids have a much better chance of going on to be normal adults and doing well. The adults in this study were identified 20 years ago, you know, a long time ago, when they were testing for more significant problems. So I don't know that these adults are representative of what we're definitely going to see. However, I do think it's important to, you know, recognize that XXYY is a chronic medical condition that's not going away, and that there are definitely cognitive and behavioral problems that are associated with it, and that, you know, we want to do everything we can to support these kids so that they can go on and be successful and be, you know, as successful as they can be. But also remember that you can't fix it. Does that make sense? So, you know, so in the 22 adults, most of them finished high school, but all had some special education supports during school. They were all fully verbal. So even though some of the kids, when they were younger, had poor problems with self-expression, you know, some of the 6-year-olds were barely talking, all of the adults can tell you anything you want to hear and keep talking, and you can see that, and they don't stop. So, you know, when parents are saying, oh my gosh, I just can't believe, is he ever going to talk? You know, I've never met a boy, an adult with XXYY, or even a teenager who, you know, they sometimes have problems with self-expression, you know, getting the words out that they want to get out. But, you know, they definitely are speaking. A quarter of them had their driver's license. Usually, they didn't always get it at 16 when you can start to drive, but a quarter of them had their driver's license, and usually it was in their mid-20s that they got it. And
Was that all due to them or to the parents who didn't trust?
sometimes both. You know, there's a lot of parents who are like, he wants to drive, but I'm not letting him. A lot of times the written test is a nice obstacle, because they have to pass the written test first. And then, you know, the parents are like, well, you have to pass this, and they don't help them study. Go ahead, take the test. You know, you can go take the written test. And so they won't, you know, because they don't necessarily trust them to drive at that age. But then they can later. And there are boys with XXYY who are driving themselves around. And, you know, we have a guy in Colorado who's driving and working independently. And when I knew him, I haven't seen him in a couple years, he was starting to get ready to move out of his mom's house. So he had his driver's license, and he was, you know, getting ready to move, and he had a job at a movie theater where he'd moved up a couple ranks, and he was working. He didn't want to do any further education after high school because he was happy in his job, and you know, he thought maybe he would go back later. You know, we've heard of other ones who are doing well, and I have some kids that I can't imagine they're not going to go on and be independent just in what we see now. However, this is, you know, what I've seen so far. I haven't seen, you know, any go on and go to university and be successful in the traditional ways of, you know, what success is in our country. And what, you know, a lot of people pressure us all to follow those types of tracks. 80% had difficulty sustaining employment due to these types of problems, attention, executive function, and poor social skills. Some did really well with nice supports. What we found is that, and this is actually, you know, that transition is a really tough time, that 18 to 22 transition of what you do after high school and all that. But then they really kind of seem to settle in. And then in their mid-20s is when things kind of are more stable. And so, you know, they find a job that works for them and that the people, you know, are supportive of any of the types of differences that they have and that they can do it. And then 10% were living independently but still needed some supports in terms of, you know, a range of things. Some people, someone going to their house every day to check in. Other ones just family supports where they were getting financial help or they were getting, you know, some sort of help from the community, you know, a community board in terms of, you know, supports going in to help with them with the organization or money or other things. You know, there were lots of others. Some were in the hospital versus long-term care facility versus home with their parents versus, you know, the wide spectrum of everything you can imagine in the adults. So.
Do a lot of the boys have trouble with the concept of time, being on time, the passage of time?
What do you guys say?
Oh, yeah. Like, please come to bed at 10 o'clock last night, and at midnight, I'm down in the lounge dragging him up to bed. And he goes, I'm 21, Mom. I'm going, baby, you should have known better.
Yeah.
He calls me and says the bus hasn't come yet, and then 5 minutes later, the bus hasn't come yet.
It's like 5 minutes
Yeah.
is an hour.
Yeah, it's like, yeah.
Usually it's an hour.
Or else it's the other way, extreme.
They do a little bit better if you can give them some visual way to see time, like a clock with a second hand is better than just an analog clock.
Well, he can't read analog clock.
Yeah.
And on a digital clock that has a flash, that actually has the seconds ticking off can help break it down a little bit more.
See, my son actually prefers the analog clock.
No, Jesse could never get the analog. He just can't read it.
No. My son's anal about it. He can tell you to the second what time it is.
Is it time to go yet?
The cafeteria closes in 45 minutes.
Okay. Wow. So we better go. So, you know, there are other pieces here that we can all talk about. But I just want to invite you all to come to the clinic if you have questions or concerns, and we can do evaluations and address your individual questions and concerns. And then it helps us know where to put your child in a lot of these things we just described. Because like we said, there's a big spectrum. And some kids are doing better in some areas and worse in other areas. And so, you know, until we meet your child, it's hard to say, you know, it's always hard to predict where they're going to be. But, you know, we can give you more information about what kind of things we feel are going to be important for them in terms of helping them prepare for future and what their prognoses are and those types of things.
And we'd really like to learn more about XYY.
Yeah. So, and I'm here. So you guys, I'm here at the party, and I'm here all night. So.